Dear students, this video is regarding the myasthenia gravis and its management. Myasthenia gravis is an autoimmune disease where there is development of antibodies to the nicotinic NM receptors at the neuromuscular junction. As a result of that, there will be development of the IgG antibodies that will be developed against this nicotinic NM receptors, where the receptor number will come down to about 1/3 of the normal or even less, and even it can even causes destruction of the neuromuscular junction, and if it affects in about 1 in 10,000 people. So there will be antibody mediated mechanism of the blockade of this acetylcholine. So normal synapse, you can see the acetylcholine, it acts on this nicotinic NM receptors. But what happens is in myasthenia gravis, there will be development of the IgG antibodies. So again is this NM receptor. So NM receptor number will reduce. Okay, free NM receptors. So acetylcholine won't able to bind to those NM receptors, or rarely binds. Okay, so this is what happens in the myasthenia gravis. So there will be formation of the IgG antibodies against the nicotinic NM receptor, which can lead to generalized weakness in the patient. Then slowly, like fatigability, easy, like they won't able to work, they do the day-to-day activities. Okay, so this is what you see in a patient with myasthenia gravis. So initially the eyelids, external ocular muscles, facial, pharyngeal muscles and all gets affected in the beginning. Later even the limbs and respiratory muscles that get affected. So this can be resolved after taking some rest. Slowly they'll recover, but there will be progressive weakness, fatigue, drooping eyelids, difficulty in breathing, speaking, swallowing, because all the respiratory muscles and all gets affected. Since the weakness is a common symptom, it is usually difficult to diagnose, and sometimes may vague, it may fluctuate, or even may affect the certain muscles. So it can be, the diagnosis, it can be established by clinical or serological testing. So the ameliorative test, what has been recommended to diagnose myasthenia gravis is to inject intravenous edrophonium 2 mg, and if nothing untoward happens, repeat 2 mg in every 30 to 60 seconds, and maximum you can give up to 10 mg. So if it is myasthenia gravis, there will be reversal of this weakness what you see in the patient, and there will be a short lasting improvement in the myasthenia gravis. But this is not seen if it is any other muscular dystrophies. This improvement you can't see. So that's how will confirm this whether it is myasthenia gravis or not. And alternative is you give intravenous neostigmine 1.5 mg with atropine pre-treatment. And more reliable test is to find or to confirm this myasthenia gravis is plasma or muscle biopsy for the nicotinic receptor antibodies. That is more reliable test what has been recommended. So it has been diagnosed. So how do you manage the condition? It is Dr. Walker in 1934 who found that or who started treating this myasthenia gravis with anticholinesterase. So initially it started with the treatment with the physostigmine. Later it it has been changed to the neostigmine. So neostigmine 15 mg orally 6 hourly will be started. So what is the rationale for giving neostigmine in myasthenia gravis? It improves the muscle contraction. How? That is by allowing the acetylcholine. Neostigmine is an anticholinesterase. So it prevents the breakdown of acetylcholine, or it prevents the hydrolysis. So whatever the acetylcholine is, the amount of acetylcholine level will increase. So what has been released from the pre-junctional nerve endings to accumulate, and that will act on the available receptors over the larger area, and it also directly depolarizes the muscle in place. So it has got a direct action also, and it also acts on the available nicotinic receptors. So that is how the neostigmine improves the symptoms in the myasthenia gravis patient. So alternatively, pyridostigmine has been recommended. It is long acting, so less frequent dosing is enough. So that's the reason pyridostigmine is preferred over neostigmine, since it is long acting. And neostigmine along with pyridostigmine. Along with that, atropine will be given. Why atropine has been given? What is the rationale? In order to, because the patient has to be on long term on anticholinesterase. So long term use, it may develop the muscarinic side effects. To counteract that muscarinic side effects, we will give atropine, which is an anti-muscarinic drug. So that's the first line, neostigmine. Which are the other drugs used? Other drugs used are the prednisolone, which is an corticosteroid which has got immunosuppressant action. Dose recommended is 30 to 60 milligram per day. So it even inhibits the production of the antibodies, NM receptor antibodies. It also promotes the synthesis of the new NM receptors also. So this can, even the prednisolone can induce remission in about 80% of the patients. It can induce a remission. And sometimes what happens is, when you start with the initial dose of the prednisolone itself, the patient may feel weakness. Okay, so slowly you have to adjust the dose accordingly. And during the maintenance therapy period, you reduce the dose. Okay, so that's how you can reduce that weakness and all in the patient. So that's about the prednisolone. Next is the immunosuppressants, azathioprine and cyclosporine. They act by inhibiting the NM receptor antibodies by affecting the T cells. So most of the time, azathioprine is the one which has been preferred, even though it has got a slow onset of action. But it is good for maintaining the remission. So that's the reason azathioprine is preferred for maintaining the remission. So these are the drugs which are preferred, or which are the drugs which are used for the management of myasthenia gravis. So first line is always the anticholinesterase, neostigmine. What has been preferred is pyridostigmine, then the corticosteroid, that is the prednisolone, then the immunosuppressant, azathioprine or cyclosporine. What is the alternative? Alternative is plasmapheresis. So usually this patient is not responding to the anticholinesterases like that, will go for the steroids and or even with the immunosuppressants. So here in plasmapheresis, there will be removal of antibodies by plasmapheresis. So it shows a dramatic improvement, but it is short-lived. So in critically ill patients, instead of plasmapheresis and other drugs, if the patient is not responding, you can go for the intravenous immunoglobulin. Even monoclonal antibodies are available, that is rituximab and eculizumab, which are recommended nowadays for the management of myasthenia gravis. What is another thing is what the surgical management with the thymectomy in the myasthenia gravis patient. So what is why thymectomy? Thymus gland is mainly which was involved in the immune response by T cells and all, isn't it? So what happens is, sometimes in patients who are in autoimmune diseases like myasthenia gravis, thymus gland can trigger some autoimmune response, so which can lead to the myasthenia gravis. So especially in thymic hyperplasia and thymomas, whether it is malignant or non-malignant thymomas, the thymectomy will be helpful in such patients. Then even non-thymomas in myasthenia gravis patient or elderly patients who are 60 years and above, the patient being on anticholinesterase doesn't show any improvement. In such patients, you can go for the thymectomy. Or even in the young adults who is having generalized weakness, patient not responding to the anticholinesterases and all, thymectomy is another option, or is kept as a last resort. Myasthenic crisis. It's an acute weakness of the respiratory muscles. It is characterized by acute weakness of the respiratory muscles. So it is managed by tracheal intubation and mechanical ventilation, and patient will be started on IV prednisolone. Pulse therapy will be started. So, and in such condition, during the patient starts with the myasthenic crisis, usually anticholinesterases are withheld. Anticholinesterases will be stopped, and slowly later it will be restarted. And plasmapheresis can hasten the recovery. Usually, it takes some 1 to 3 weeks for the patient to resolve out of this myasthenic crisis. Overtreatment with anticholinesterase. Yes, this can also happen when, because if you don't taper, adjust the dose in a myasthenic gravis patient, so high dose or for a prolonged time on a higher dose, it can lead to the weakness due to the persistent depolarization of the muscle end plate. So you won't be able to distinguish whether it is myasthenic crisis or cholinergic crisis. So in such cases, hydrophonium will be given 2 milligram intravenously. So if you find any such improvement in such cases, it is myasthenic crisis. But if the condition of the patient get worsens, yes, it is cholinergic crisis. What has to be done is you have to adjust the dose, decrease the dose of the anticholinesterase. That's how you diagnose it, whether it is a myasthenic crisis or the cholinergic crisis, what you see in the patient. So that's all about the myasthenia gravis and its management. So these are the differences for the further reading. Thank you students. Happy learning.